So case study number 4. So same setup. All right. So labs. All right. So now the interesting thing here is that all these labs. All right. So right away, all these labs. Once again, when we have all these labs, they're exploring what's going on with this patient. It doesn't make sense, right? So it's not really the patient's very specific, so we don't really know what's happening. So there's a lot going on. Right? So that's the first thing that you start to recognize. All right. So the next thing is that let's see what we have here. So we have our labs. All right. So pretty much benign. So I would think almost automatically, okay, it makes sense, exploring, right? So nothing really episodic here, right? But I mean, there's probably something episodic. I just don't have any data here. There's nothing here that's screaming there's a physiological process, right? So I do have this right here. This is a little bit elevated. So that brings me over to diabetes a little bit or pulmonary, but I'm not sure yet. I need more data. Everything else looks benign. So let's keep going. All right, so I look at my organs, renal, coags, liver, and then cholesterol. What do I have here? Well, I have a total renal, which is also points back up to here, to renal again, which is interesting. So I find that very fascinating. I'm not sure why, so I need more data. But I do have this right down here. So I have an alkaline phosphatase that is elevated. That's from my liver enzyme, so that's weird. So I do my liver enzymes. So I do AST and ALT. All right, so we said that this is 3, 4, 5, 6. And then this looks like a 10. So you go 10 to 40. And then you go 10 to 50. All right, so then we said down here is your alkaline phosphatase. And the way this goes, you add these two 10s together. You got 2120, 2120, 2120. All right. Now, what that is that, these are kind of ballpark numbers, all right? Now, we only worry about high. We don't worry about low, okay? With this enzyme, the only time you worry about low is albumin, okay? Everything else is high, all right? That's what you worry about because these are enzymes. Enzymes are so when a cell breaks, spits out this enzyme. Remember ACEs, ACE enzymes? So troponin, right, gets broken out, spills out. So that's what you're talking about, AST, ALT. This is a little bit more specific, L to liver. This could be system. So if somebody has systemic infections, they can have an elevation of their AST. It is liver, but it could be system too, right? But this is only liver. This is elevated at specifically liver. All right. So enzymes in the liver are kind of like smoke, where you have a fire, okay? And you had a fire, and if you saw smoke, you wouldn't put your hand in those coals, okay? So that's how the liver works with these enzymes, right? So if somebody was drinking, they would start to spill enzymes. Even if they stop drinking, they're still spilling enzymes. Okay, so as the body's healing itself, you're going to still have elevations of these enzymes. They're still going to be there. So it's kind of like where there's smoke, there was fire. Okay, so if somebody has something liver toxic, they'll still be smoldering these enzymes post. Okay, and so that's why they're always very cautious whenever you see elevations of liver enzymes. But the interesting thing here is down here, this 123. Well, that's called biliary. So anything down here, so this is liver, and then this is biliary. And biliary, when you start talking about biliary and gallbladder and all that stuff, your biliary tree, where bile is secreted and all those types of things. Well, that's concerning because this is biliary. And so when you have biliary that's elevated, you will then look at a GTT. Okay, which is biliary related, right? Which is mainly about this. And when you have sludge in your gallbladder and gallbladder pain, so what happens is, okay, so you go to, you talk about Whoppers, right? But mainly McDonald's, you go there and all of a sudden you get this back shoulder pain, that's your gallbladder saying, hey, keep on eating that, okay? That's your gallbladder talking to you on your right shoulder. Right, that's your gallbladder. Because the position of it is your liver is here and your gallbladder is behind it. So when it becomes inflamed, it hits the back of your scapula. And so that's the first characteristic sign of it. That's different than pancreatitis. Pancreatitis is on your left shoulder, right? All right, so that's characteristic. So this is elevation. So I always think GDT 30, T3 30, and that's where it's 0 to 30. And but if you see this being drawn, there's a biliary problem to this patient. Okay, so what's going on? Why is there a biliary problem? Well, I mean, who knows? There's sludge in there. It's probably diet related. You know, it's like if you start to have, you know, you have a poor diet, it's going to start to mess up your gallbladder. Your gallbladder is the first to go, then your liver. Your liver can regenerate itself, but the gallbladder is a big problem. Now, the interesting thing about the gallbladder and the biliary tree, and this is pretty fascinating, is that on your certain people out there, you know, that are even sitting here, you know, everybody's got a liver, and we know that. And your liver has the biliary tract, and you have your gallbladder, right? Well, the fascinating thing about that is some people, majority of the population has this, has two bifurcations, but some people have one, right? And the problem with this is left over from years and years and millions of years, and they don't quite know, you know, which population and why they've acquired this, you know. And we'll talk about this later about, like, you know, how African Americans, you know, why, you know, they have such a high propensity to kidney disease and stuff like that. And it goes back to Africa, salt and maintenance of water volume and all these types of things, as far as, you know, just the ecology of the area. And we see this with, you know, Eskimos and their diets and all these things. And this is, we're talking thousands and millions of years of this evolution. You know, I mean, let's talk, you know, not talking religion, we're talking just adaptation, you know, of the body over the thousands of years. All right, so anyways, long story short, too late. This right here, some people have this. These people who have a cingulary, they get the gallbladder a lot. And that's why some people will get their gallbladder out and some people won't. And what usually kicks on is once you get, now the liver secretes bile as well as the gallbladder. So when you get rid of your gallbladder, your liver will take over. But you have to still watch your diet and everything like that. So that's why some people will get their gallbladder taken out and some people won't. Another thing too is that the pancreas connects to this. And, you know, the pancreas connects to it. And so if you have history of gallstones, or you can have a high risk for pancreatitis as well. All right, so anyway, so that's fascinating because this is all biliary. So it's probably diet related by looking just at this. You know, I mean, you know, there's probably your really high cholesterol, you know, it's probably a lot of sludge because cholesterol is made in the liver, right? So there might be some alcohol involved, and there might be some other things. So let's keep going. We need more data. So what else we got here? What meds? I would like to see, you know, cholesterol meds. I mean, that would be ideal for this guy or women, you know, it's probably a guy though. And then, and something's going on here, and I just need more data of what's happening. So let's go. So we see hydrochloric thiazide, okay, he's probably non-compliant. Pseudoephedrine, okay, probably has allergies. Okay, also allergies. So that's just whatever. I generally never ever rate the dosage. All right, I never report on the dosage. And the reason is, do you know what a normal hydrochloric thiazide dosage? It says nobody ever. So therefore, why do you talk about it? Right? I wouldn't know what the difference is, right? You know, and I'm going to look at them more when I'm going to see it. Just tell me they're on hydrochloric thiazide, right? Tell me they're on pseudoephedrine, right? I don't care what the dosage is. I don't even know what the normal dosage is, right? Maybe if I was making meth, I would know, but, you know, I'm not. So therefore, you know, why does it matter, right? Now, so there's some sinus stuff here. There's hypertension. So let's keep going. All right, so with diagnostics, I don't know. Nothing really here screams out to me. You know, even if he is hypertensive, I mean, this is okay. You know, there's nothing there. So there's nothing really other than this biliary cholesterol stuff going on here. So let's keep going. Okay, well, I see an echo. Okay, so I see an echo um, with the ejection fraction of 46%. Well, that's bad. So he's got a 46% echo, which means he's probably going to be symptomatic. It's going to have hepatosmegaly, which could also elevate some of this stuff in here. But it's left-sided, so I keep on looking at it. What else do we have? We have a low voltage Vcg. Okay, so let's talk a little bit about that. Low voltage is because of, now you remember we just talked about in the previous one as far as the isoelectric line. We said 0, then we said plus, and then minus. This is voltage, right? So something is causing it not to have enough voltage, right? And how does that happen? And there's two ways because of that. Either you have this going on, you get a floppy doppy heart, cardiomyopathy, it's already wasted, right? Blowing the balloon, blowing the balloon, or you have a hypertrophic heart. So we'll look. So we see clinical evidence. We say increased voltage suggests a left ventricular, and then left ventricular ejection fraction. Okay, so thanks for that. Then we have assessments, and then we see, okay, so we see hypertrophic heart. Okay, so hypertrophic heart, and we talked about this yesterday, right? We talked about this in lab yesterday. We said on a hypertrophic heart, and now you see S3 showing up. Now, let's talk about that. Now, I drill in your head about S3PE, okay? Because that's most likely. Now, S3 sounds can be hypertrophy. Okay, so, and the reason that is, so let's talk about that. So you have your four chambers of the heart, right? If you're hypertrophic, right, you're going to output less ejection fraction, okay? And what's going to happen is you are going to start to, if you're hypertrophic, you're going to have like CHF-like symptoms, right? So what happens when you have extra heart cells? You have all this volume out here. Well, that volume is going to come back to this heart. And when it comes back to this heart, there's so much volume out here, it pops that valve. So you hear the extra heart sound, and that's the S3. So it's out of sync with the other side, and that's the S3 sound. Okay, what it basically means is that they're filling up with fluids and all those type of things, but it's not as ominous as S4. Now S4 is all the valves are all pop, 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 right? Where this is just 3 sounds: Kentucky, 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 right? Kentucky. Where Tennessee is 4 sounds. All 4 valves are opening and closing at the wrong times. Okay, so this, an S3 sound is an impending problem that this patient will be walking and be short of breath a lot, okay, because they can't quite, get their cardiac output, because why? They have a hypertrophic heart, and this is what we talked about before. They can't get that volume and get that pumping, all right? All right, so basal we talked about that yesterday when we were doing our assessments, and that shows up again here. So how I write this is generally, I just put that, this is my physical assessment over here, and I just write S3, I do a hypertrophic heart, and I'll do crackles, and that's good enough for me. I'll do anything more than that, And I could say that, whatever. All right, so moving through, for history, well, hypertension definitely from here. Allergies, I'd like to see hyperlipidemia, because that's definitely happening. But he's on nothing, which is weird for this guy. So either, he's just eating crap all day, basically, right? And he's just a drinker or something like that. So let's see. Chronic sinus, we know that. Hypertension, yeah, okay, it's probably non-compliant. Pneumonia, 6 years. Well, that's odd, This means he's sedentary. He's not moving. He's eating crap, all those type of things. Plus with this, people who are on these sinusitis, dries them out. Think of dehydration, right? If you're always dehydrated, you have more risk for infections. That's kind of why they don't stay hydrated. And that's why hydration is a big key for these patients. So he's probably not drinking water on top of it, stuff like and basically dry a lot. And All right, so let's keep going. What do we got? All right, so no surgeries, major depressive, okay, whatever. Let's pull it all together, mission diagnosis. I still don't know, right? I mean, there's nothing here that says anything other than maybe shortness of breath. Shortness of breath. That's about it. Like, there's nothing here. You can't close for me with what I see here, right? Because I wouldn't admit a patient for hypertension, right? I wouldn't, he doesn't have pneumonia now. There's nothing here. So there is nothing here other than this stuff going on right here. So probably symptomology, shortness of breath, not feeling right, feeling tired, all those type of things, just having a general ill feeling and trying to figure out, what's going on. So it's probably a follow-up or something like that. And then so you go forward and you see, okay, 40-year-old, if he's young, but he's got this going on, it's bad. Difficulty calling his hypertension lately, visiting primary care through, okay. And then he smokes cigarettes, okay, several beers. All right, so several beers. Okay, so you always times that by 3, right? They say double, but that's actually times 3. What's several to you or I? I have several beers. Okay, so you have a 6-pack a night, okay? And so he's probably drinking about 12-pack a day. And that's give or take, you know what I mean? That's on a good day. Right? So that's a reality of what's going on, and that's going to destroy his heart. Actually, they tend to get a little bit more dilated, but they always have CHF issues generally with alcohol. It does something to the kinetic nature of the heart. It really wipes them out. But this biliary is probably related to cholesterol, and that's related to the alcohol and to the liver. So he needs to be on it, some sort of cholesterol medication. Stop drinking. Who consults our cardiology because he's not on anything. He's just on this. This is not working for him. I don't know why they have him on a fluid one. That's interesting, right? He has no ACEs. He's on a hyperthyroidism. It's just going to work in the renin-angiotensin and, thiazide, loop diuretic, kind of, sort of, but not really a mechanism. This guy needs something more in depth, for him. He's young. He's 40, so, that's old to a lot of you guys, but, old guy like me. All right, so, again, nothing here, no code status. Thanks for that. And then, why would he be readmitted? Probably stroke, shortness of breath, CHF-like symptoms, or recurrent pneumonias, being sick. That's probably what would happen. He's a candidate for an MRI, this guy. Also for general ill feelings over and over again, sick a lot, those type of things. All right, so cardiomyopathy, right? So hypertrophic, you have cardiomyopathy here, and you're thickening. And then, so we tend to do this, see calcium channel blockers. That makes sense, soften things up. Amiodarone, generally not. It's not the first line. And we'll talk about that when we get to week 4. Generally not Lasix, because you think about it, there's not much fluid in there, right? So, he needs all the volume he can get in there, right? So, but the problem is that he can't fill it up. That's the issue. It's not that he can't get, it's not that he has the viscosity. He just doesn't have the space to get the cardiac output. So generally not ACE inhibitors, no diuretics, digoxins, because you can't pump this, right? It's bad. May have syncopal episodes because he can't get the cardiac output. He's orthopnic, so this person lays down, he starts to get short of breath, right? Because you think about it, this heart is like this big freaking thing. So when a person lays down like this, what basically happens is it closes, get it? All the pressure will just kind of close that heart and can't really pump. So they feel very orthopnic. They can't lay down and those type of things. You see this a lot with aortic stenosis. Aortic stenosis, if you have aortic stenosis, what happens, the problem with the aortic stenosis is the heart. When you have the heart like this, an aortic stenosis is the stenosis of the aorta. And these people, they go to sleep and they die. They never wake up because this collapses on itself, and they never woke up from that nap. Sad. All right. So, anyways, They can have angina, pulmonary congestion, most likely sudden death, and that's kind of why it's a big risk. There's the Peach Club, which is SC3PE. Athletes can get this, but it's manageable. Cardiomyopathy, hypertrophic, thyroid just because of pump. Anemic patients, just think of volume. And then pregnant because of circulatory. Right. All right, so this guy's walking around. Symptoms 3, shortness of breath, CHF symptoms. Precipitating it is poor lifestyle, diet, all that stuff. Main concept is hypertension, but it's related to his poor lifestyle. Main complication is death, and S3 sounds. Q3 is shortness of breath. Nursing 7, right? Cited mentation problems because of poor perfusion, heart issues, shortness of breath. Eventually, because that could cause renal issues because of hypertension. Surgical, no, not necessarily. He needs cardiac rehab. Put him on a monitor, ST depressions, vital signs, blood pressure be down and up. Labs we already covered, and then it's mainly probably fluid with this patient. All right, that's hypertension in a nutshell. Interesting though, right? Different than a normal perspective on hypertension, right? Like you normally just like hypertension, okay, blood pressure, right? I mean, but there's a guy who had some cardiac abnormalities from it, and actually affected his heart. So it was fascinating. I found it fascinating because of that. And actually, it was kind of what we were talking about yesterday with the assessments. You know what I mean? And when we were doing the heart sounds and all that stuff.